Good afternoon. Today I'll be talking about early lung cancer screening saves lives. Hi, I'm Dr. Cheah from Island Hospital. I'm a clinical oncologist who deals with treatment of lung cancer, be it with systemic therapy or radiation. So obviously we know that screening saves lives in various types of malignancy, including breast cancer, gynecological cancers. So recently we also have some strong scientific data to back up that those patients who are at risk and undergo lung cancer screening will also lead to an improvement in survival outcome. My talk today will be divided into the first section where I will show you some of the data, and subsequently sharing some of the local epidemiological data, treatment options, as well as some of the regular questions that are being asked regarding lung cancer as well as screening. More than 10 years ago, we also know that CT screening by using low doses without IV contrast can detect lung cancer at an earlier stage. Now, from the historical data, a patient with stage 1A, stage 1B tend to live longer. They have 5-year survival of at least 50, 70, 80%, and we know some patients even have survival of above 90% if they were able to undergo a curative treatment, for example, surgery in the past. Conversely, if we were to look at those patients with advanced stage, for example, stage 3B, stage 4, the survival seems to be dismal at around 10%. Of course, these are historical data, and advances in systemic therapy has improved this somewhat. Next slide. Now, in the midst of COVID-19, a publication coming from Netherlands and the Belgium group came, and this data is now establishing CT screening as a form of to reduce lung cancer mortality in this subset of population. Of course, these CT screening are done for patients who are current smokers or have already smoked for about 25 to 30 years with cigarettes ranging from 10 to 15 sticks. They do CT scan at about 0 times 0, 1 year, and also at about 2 and 5.5 years. So a total of 4 CT scans were done. This study managed to show that for this subgroup of population, by doing CT screening and ability to pick up earlier stage of lung cancer, they managed to demonstrate improved survival. We can see graphically the incidence increases in the first few years compared with those patients who are on the control group where they have no screening. Obviously, this is because of ability of the screening to pick up cancers, and usually at an earlier stage. With a minimum of 10 years of follow-up, the investigators able to show that in this study, screen group managed to have a significantly lower mortality compared with those who undergo no screening at all. Now, the reason is fairly obvious. As we can see here, patient in the screen detected group tends to be diagnosed with a much earlier stage of cancer. And as I have discussed earlier, a patient with stage 1 may have an overall survival at 5 years of more than 90%. And now we are seeing, instead of 50 to 60% of patients in an advanced stage for those with no screening, those who have a CT screen manage to pick up the disease much earlier, and the reverse is seen. About 60% of patients are detected at an earlier stage, therefore amenable for curative surgery or other treatment. Now, I'm going to quickly show you some of the epidemiological data so that we can understand and also to extrapolate the results from studies conducted in other countries. They are not necessarily the same because smoking pattern as well as genetic factors are different for different countries. The GloboCan data, which was recently published, looked at the number of cases in Malaysia in 2018. Out of 32 million Malaysians, about 44,000 new cases were reported. As you can see, the total number of cases in males about 20,000 and in females about 23,000. Lung cancer, unfortunately, is the top number of new cases, incidences in males, and that consists about 16%, about 3,500 patients. Whereas in females, it is ranking slightly lower, obviously, because of the other malignancies such as breast and cervix and ovarian. So lung cancer is lower, about 5%, and the number is about 1,200 cases. Now in the UK, this is the report coming from Cancer Research UK, and they look at smoking pattern and also the incidence of lung cancer with a European age standardized incidence rate between 1948 and 2017. So obviously, the females in our population generally do not smoke as much as some of the Western countries or developed countries. However, we are seeing a trend in male lung cancer patients whereby a drop in smoking pattern leads to a drop in the incidence of lung cancer in males. However, in the female population, although there is a decrease in the smoking prevalence, the incidence of female lung cancer is increasing. There are various explanations for this, including possibly a higher sensitivity, or possibly because of a late peak of smoking pattern among females. It is still quite controversial. However, these are the data that has been presented. We see an increasing peak of lung cancer incidence as they grow older. This is understandable because genetic changes, carcinogenic changes takes time. The difference between the genders seems to be quite similar until around the age of about 60, where males overtake females, and you can see a higher incidence among males. However, both increased incidence occurs around the ages of 60 to 80. So that is just a quick introduction of the epidemiological data, the differences between gender, as well as increasing incidence with age. Now for those who are not well informed or they wanted to know more about lung cancer, I've put up a few slides to show you the basics of lung cancer. I also understand that among the audiences today, there will be young adults, housewives, even school children, as my young daughter, the eldest daughter, is also probably watching this Facebook Live. It is probably for the benefit of everyone that we share the information from this short presentation. Hopefully we'll be able to inform our parents, your spouses, or your grandparents on the importance of screening for lung cancer. So lung cancer typically starts in the cells lining the airway, namely the bronchus, bronchioles, or alveolus. Two main types of lung cancer usually seen. This consists the non-small cell type, which is the majority of about 80%, and a smaller proportion, about 20%, being small cell. Small cell being more aggressive and more difficult to treat. The risk factors can be unknown. However, smoking is by and large the most important factor. And when you compare between a smoker and a non-smoker, the risk of developing lung cancer is at least 20 times higher. There are some environmental factors, for example, people who are exposed to tar, pollutants, exposed to smoke, as well as some radioactive materials. Someone with history of lung infection in the past, for example tuberculosis, may have an increased risk of developing malignancy. And obviously, people who don't smoke, especially in the local setting, I have quite a significant proportion of females mainly who are non-smokers who are diagnosed with some form of lung cancer with molecular aberration. So definitely there is a role where the genetic aberration plays in developing lung cancer. This is just a cartoon showing that the signs and symptoms of lung cancer can be quite diverse. In fact, by the time you develop these symptoms, the disease may have already spread to other parts of the lung, or we may not or no longer be able to cure the disease. That is the reason why we do screening, because a lot of cases of early stages, stage 1 and stage 2, they have absolutely no symptoms and incidentally detected via CT scans or blood tests. But just to recap, for those patients who do have symptoms and they need to consult the nearest medical providers, take note of the 10 common symptoms of lung cancer. Number 1 is chronic coughing for more than 2 weeks, especially if you were to cough up blood. That is a red alarm sign. A patient with wheezing sound, and patients with bone pain and chest pain. Not infrequently, I have patients coming to see me with metastatic diseases. They have headache, they have blurring of vision and bone pain. But that is not a very good sign. Chest infection sometimes can mask an underlying malignancy, and not infrequently we see cases with tuberculosis suspected for a couple of months, in fact, and subsequently unmasked and diagnosed as a lung malignancy. A patient may have difficulty swallowing, as well as hoarse voice. That is due to a local compression from a tumor which is located very close to the airway or to the laryngeal nerve. And patients with shortness of breath, unexplained weight loss, as well as nail clubbing. So there are many other symptoms which can manifest, and there are also non-specific symptoms where they can have paraneoplastic syndromes unrelated to the local effects of the tumor. I do get a lot of questions on patients and misconception that sometimes they may refuse to do a biopsy, but for a doctor, evaluation by the chest physician with a bronchoscope or by doing a biopsy is of utmost importance. Treatment is now based on molecular aberrations. We are depending a lot on the histological confirmation as well as a form of confirmation of the stage. Only very rarely, if you're not able to perform these procedures, sometimes by using the blood to analyze for genetic aberrations, but that is a very rare situation. So I do want to emphasize that these are one of the most important aspects in not just diagnosis but for management of lung cancer. The stages of lung cancer can be divided generally into stage 1 and 2, 3 and 4. The early stages, where the tumor may be confined within a lung, one particular lobe, or within a small size of less than 3 centimeters with no metastasis to the regional lymph nodes. As the disease progresses, the tumor may subsequently metastasize to involve regional nodes as well as the contralateral lung, and subsequently they may even manifest or metastasize to areas outside of the lung, including brain and bone, but that is usually an advanced stage. I'm just going to touch briefly on the general management of lung cancer. Historically, a cure from surgery for stage 1, stage 2, and some select cases with stage 3 cancer. Radiation can be used as a form of adjuvant or as a form of palliative care. advancing technology has opened up a lot of opportunities, and radiation oncologists and clinical oncologists like myself have begun to adopt a more advanced technique called stereotactic body radiotherapy, both to the primary or to metastatic lesions. We no longer depend on chemotherapy. About 20 years ago, that's the only weapon we have, the only bullet, so to say. But now we have various forms of systemic therapy, including targeted therapies, as well as immunotherapies. They have become our good friends in a way. Now patients have more options, and sometimes even a patient with stage 4 lung cancer can be treated, sometimes with long responses beyond 10 years is possible. So that is my last slide, and I'll be happy to take any questions and in the segment. Do we move on to the question? The first question. All right. We will be waiting to see if we have any questions from our listeners. But one of the questions we are getting here is that, can I get lung cancer if I don't smoke and stay away from secondhand smoke? Well, as I've explained, we get quite a fair bit of patients, especially females. They can be quite young, sometimes even as young as 30s, 40s or 50s. They don't smoke, they are single, they're not exposed to secondhand smoke as well. So they potentially may have a molecular aberration, and one of the most common molecular aberration that we see is EGFR mutation. So these patients sometimes can be subjected to a targeted therapy. Okay. Previous experiences, we do get cases where they don't smoke, but they are exposed to a lot of jaw stick. They are exposed to work-related dust, for example, carpenters, those who work in paint shops. They are exposed to a lot of fumes, and these are all toxic carcinogenic material which, when exposed for a long period of time, will lead to malignancy. Now I'll move on to the second question, which is, of course, we probably may not have the answer to this yet. Will COVID-19 increase my risk of lung cancer or lung complications in the future? We don't know for sure, but based on our previous understanding and also cases of an increased risk in patients with tuberculosis and other forms of infection and lung injury, there is a possibility that they may have a higher chance of developing malignancy or lung complications. But we can only look to the future, maybe in 5 years or 10 years time, before we can ascertain the risk. Just like the Hiroshima atomic bomb, we can only see the increase in leukemias, malignancies many years down the line. Now the next question that is, are women more susceptible to certain types of lung cancer or lung cancer in general? So it's not, it is also quite controversial. There are some studies which have seems to suggest that yes, women may be more susceptible, especially to smoke, compared with males. They may have some molecular aberrations which may lead them to develop a more aggressive form of lung cancer, but generally a lot of clinicians think that this is still not something set in stone. We do not generally say that females are more susceptible, but generally similar between the genders. We do have a question from a patient, one of our listeners here. Will haze increase the risk of lung cancer? I believe yes. Yeah. it is a form of a pollutant, and I said environmental factors, one of the causes of lung cancer. We recently, not just in our country but also in the Asia Pacific region, especially involving Malaysia, Indonesia and Singapore, we're exposed to haze problem every year. So we have this about 10-20 years ago. I remember when I was in school and we don't have to go to school for a couple of days. So similar to the COVID-19 infection, exposure to haze probably will lead to an increase in lung complications, infections, and I would not be surprised if lung cancer incidence increases probably after about 10 to 20 years. So there is actually a latent period before developing malignancy. We have another question. So what are the screening tests available? Well, I must say that in the Nelson study, they look at current smokers as well as heavy smokers, ex-heavy smokers. Most of the women I see don't smoke, especially in the local setting. So we don't compare with the Hispanics, we don't compare with British in the UK. So I would say that for starters, we probably should be doing the basics, such as at least a chest x-ray to begin with. We may need to do some blood tests to look at the white cell, maybe to look at some of the markers. And not infrequently, we have patients coming with absolutely no symptoms, and sometimes the x-rays are a little bit fuzzy, we don't see changes. But one of the red alarm signs are increased tumor markers. I don't really go to the street to ask everyone to do tumor markers, but it is a fact that we have patients who come here on demand and they have the test done, and we pick up malignancies, various types in fact, just from blood tests as well. But to be very specific, in lung cancer, a low dose, non-contrasted CT scan is probably the best way to pick up very small nodules, and that is the time when you pick up early stages of lung cancer and able to proceed with curative treatment. Now there are cases who are elderly, or they feel that anesthesia is too risky for them. There has been many reports coming out where we use radiotherapy, high dose of stereotactic radiation to the lung, and the results are fairly similar with surgical outcome. Now it provides an extra option for patients, especially those who are medically inoperable, extremely elderly patients, or patients who have very poor lung function. Sometimes we have this extra option. Okay, so to answer the question, any specific screening tools? Yes, we just have to combine various forms of imaging. X-rays first, maybe to do a CT scan, and also blood test. Okay, so I'll be moving on to the next question. So at what age or point in my life should I consider getting lung screening? Well, I think every one of us who were to venture to university life or work, we do get an X-ray done. The benefit, survival benefit in the studies, they are looking at patients with high-risk features. So for the normal person who is a non-smoker, I don't think everyone should get a CT scan. So that's definitely not the right thing to do. So it probably depends on the risk factors that they have. For example, if they have a strong family history, they have frequent symptoms. Of course, but by the time you have symptoms, sometimes I say that it is a little bit too late to get screening done. So as we age, I've shown you that the incidence of lung cancer increases, especially around the age of 60 to 80. But it's already slowly peaking between 40 to 60. So I will say that it is general understanding, although I do not think that there's any specific recommendations coming out from all the medical bodies. Probably getting a screening at least every 5 years is a considerable, probably an appropriate way of trying to rule out lung cancer. Okay. So we have a question here on what is the survival rate from lung cancer. So that we will have to go back to our first slide where I show you the various stages. For example, stage 1. I believe that stage 1, we are not just looking at about 70 to 80%, possibly higher, and some of the surgical series are reporting survival of above 90%, even 95, above 95%. And the survival reduces as we go on, stage 2, stage 3. Now, stage 4 historically has been reported to be in the region of about 10% or less. But I believe with systemic therapy and also a lot of novel therapy, we are already able to extend a patient's life close to 2 years, 3 years, or even more. We have case series whereby a patient with stage 4 cancer and taking just a single pill every day, able to live beyond 10 years. Okay, so it depends on the type of malignancy and also whether there is any particular treatment which may be able to extend life. You have a next question? Okay, so how frequently should low dose non-contrast CT screening be done? From the study, they do it 4 times, and after that they stop. All right, unless if this indicated. So they do it at baseline, at 1 year, at two years, as well as about 5.5 years. So roughly about that. So if the reason for doing all this is because they suspect or they monitor a particular nodule that they can see from the baseline. For example, patients who already have a CT scan for that particular period, for example 5 years, and they found that there were no lung nodules. For sure, there is always a possibility that that particular screen populated patient may develop lung cancer in the future. But if we were to follow the exact protocol, that is what has been done. Now, what do I do in the clinics? So obviously, I do not frequently do a low-dose CT screening. I will usually do a simple chest X-ray first, and subsequent to that, if there is any strong indication and risk factors, we will be able to consider a CT scan. So I will still follow the risk criteria from the trials. If they are current smokers or heavy smokers, ex-heavy smokers, then they fall into that criteria for CT scan. Any questions from the? No. So the next question that I have will be, will my lungs be the same after surgery, radiotherapy, or chemotherapy? So there will be some form of reduction of lung volume, as well as some form of toxicity. So that can be a form of chemical reaction called pneumonitis due to chemotherapy, targeted therapy, immuno or radiotherapy. But as long as the lung reserves are okay, the patient may actually be able to continue with a good quality of life. So all these forms of modality, the surgeon or the physician have to assess lung volume and lung reserve before offering any form of treatment. Will there be limitations to my lifestyle after lung cancer treatment? So this is related to the previous question. It depends on the lung reserve and also the toxicity of treatment. There are many patients who are already elderly, after undergoing surgery, radiation, able to lead an almost normal lifestyle. Of course, they have to continue with normal habits and healthy habits such as exercising regularly, at least a few times, half an hour a day. A healthy diet consisting of various and diverse nutrients, and of course sleep well and also manage your stress level in order to prevent any form of carcinogenic changes. Of course, sleeping well as having control in your stress as well as stress management is important, because we've seen patients who are continuing with such a healthy habit such as eating well, exercising. They not only do well during treatment, but potentially may be able to prevent reactivation of cancer. So is it true that long-term exposure to petrol fuel and diesel contribute to increased risk of lung cancer? I believe so, because these are carcinogenic agents. So any carcinogenic agents over a long period of time, 5 years or 10 years, may lead to development of not just lung cancer, but also many forms of malignancies. Now, of course, I don't really treat lung cancer alone. I have cases who are being exposed to smoke. They potentially can develop cancers in the bladder as well as any other parts of the body. Now, what happens if lung cancer remains or recurs after initial treatment? Will my condition become more severe? Obviously, if it recurs, treatment tends to be a little bit more complicated, but doctors don't usually give up so easily, and we always think about various methods to try to salvage. And salvage treatment can consist of either surgery, radiation, or systemic therapy. So I don't have any further questions, and we are right on the dot. We are 3:35. So thank you for listening, and if you have any further questions, I believe our marketing side will be forwarding the questions to me. Thank you very much.